Thank you. I'll go quick. So I'm presenting the second case of this first ever joint collaboration GCI and BSBCS tumor board. I'm very happy and proud to be a presenter here. So this case is about a diagnosed case of left breast cancer at the age of 59 years. Her current age is 70 years. She is a female. Comorbidity, diabetes, hypertension, asthma. There were no family history of breast cancer or other malignancy. She is postmenopausal when she was diagnosed first. She presented with left breast lump in first quarter of 2008. FNSC showed invasive duct cell carcinoma. It was long back, 2008. She received 3 cycles of neoadjuvant chemotherapy with taxane and anthracycline. Then she underwent modified radical mastectomy with axillary clearance on third quarter of 2008. Biopsy revealed invasive duct cell carcinoma. It was ER/PR positive and HER2 negative. Then she received 3 cycles of adjuvant chemo with taxane and anthracycline. Patient was started with tamoxifen for 1 year, then switched to letrozole for 4 years. Patient was on regular follow-up. Then in 2014, she was doing well all before. Then in 2014, on her regular mammogram, there was a suspicious lesion seen. It was BRAF 5. So ultrasonography of the right breast was also done. It showed ill-defined hypoechoic mass lesion around 2 centimeter in size with large axillary lymph node, not very big, around a centimeter. FNSC from the breast lesion was done. It was duct cell carcinoma, invasive. So again, the plan was 3 cycles of neoadjuvant chemotherapy with taxane and anthracycline, and this is right breast I'm telling about before we are dealing with left breast. So again, right breast conserving surgery was done with axillary clearance, and this time histopathology report came, ductal carcinoma in situ right breast, no invasive component seen, deep margins are free, 22 lymph node negative for metastasis, ER/PR all were negative. It was triple negative. So patient received 3 cycles of adjuvant chemotherapy with taxane and anthracycline. Radiotherapy to right breast was given, 50 Gray 25 fraction to whole breast, followed by a boost of 10 Gray. Completed second quarter 2015. PET-CT was done in fourth quarter 2015. It showed a sternal metastasis. It was very painful, so palliative radiotherapy was offered, 30 Gray in 10 fraction to the bony lesion area. She continued to have letrozole, was in regular follow-up since 2016. Then 2016, she was followed up with a PET-CT scan. It showed no recurrent residual disease anywhere. PET-CT in second quarter 2018 showed disease progression in multiple vertebrae. We have done this PET-CT because the patient was complaining of bone pain, but there was no cord compression. She was offered chemotherapy, gemcitabine plus capecitabine, 6 cycles with zoledronic acid every monthly. Progressed in cervical vertebra in fourth quarter of 2018, presented with severe neck pain. Palliative radiotherapy to cervical vertebra was given, 30 Grade 10 fraction. Good pain control achieved with the radiotherapy and started with exemestane, continued monthly zoledronic acid as well. Patient was reasonably well in 2019. Then again, she was complaining of back pain, which was in control. So we did a PET scan in first quarter 2020. It showed there are vertebral mass which has progressed actually, and also the sternal area is progressing as well. This is previously irradiated area, and this area is showing uptake again. Here you can see the sternal uptake, and also vertebral uptake can be seen. So her current performance status is ECOG 2, pain and swelling at the sternal area, which is previously irradiated. Comorbidities are well controlled. We wanted to do a biopsy because it's a bilateral breast cancer. One was ER/PR positive, one was triple negative. So biopsy was a must that we decided, but the patient is not willing for any biopsy at this moment. So pain is now relatively on control with fentanyl patch, 50 microgram every 72 hours. So my question to this board is, what is the next treatment plan? One, is a new biopsy required? Although we have offered, still we want to discuss on it. Does ER/PR HER2 status change after NSCT? How to differentiate contralateral breast cancer, whether it has metastasized or a new primary one?
I can start. So I think it is a very confusing case. She's done very well if you consider that she was first diagnosed in 2008 and here we are in 2020. So it's a 12-year journey. And in fact, if you count her hormone-positive breast cancer in 2008, discount her 2014 hormone receptor negative breast cancer, she did not develop her bone mets until the second quarter of 2015, so 7 years after that. So, but temporarily, it makes sense that the bone mets is a representation of her hormone-positive breast cancer. So, if you look at the natural history of breast cancer, this is making sense as hormone-positive breast cancer. However, it is very difficult, I think, to make that assumption when you also have triple-negative breast cancer, which you treated aggressively with chemotherapy, and I would have done the same thing. And you got a pathologic CR, it seems, right, at the time of the surgery. So definitively treating that, I guess the question that would come up is, right, okay. So, the question that comes up, because we would not have normally staged someone presenting with what appears to be early breast cancer, and I'm talking about 2014, if you had staged her then, would you have seen the bone mets? And if you had seen the bone mets, that would have been the time to biopsy it to show if that was hormone-positive disease related to her primary breast cancer from 2008 or metastatic triple-negative breast cancer now presenting in 2014. Since you're not telling me that there's disease and the PET doesn't show disease in the liver or the lungs, I think it's a local problem of the breast that's triple-negative 2014 treated definitively, and now you're dealing with metastatic breast cancer in the bones. Now, it's very difficult to say that that's what's happening without a bone biopsy. So yeah, I would actually like to see that. And in terms of conversion from hormone positive to hormone negative, there's a report out of China where they looked at primary breast cancers and paired specimens from metastatic sites and showed a conversion from hormone positive to negative in as high as 26%. So again, whether or not there's been a conversion to hormone negative disease in the bones may explain the progression on endocrine therapies. And in terms of her next treatment, it depends on if it's available, but she has not seen a CDK4/6 inhibitor. So here in the United States, we would put her on a CDK4/6, either palbociclib, abema, or ribociclib, and probably pair that with endocrine therapy.
So we can put this patient on palbociclib plus a hormone like exemestane. That is possible.
Yes. Yeah. Or how about
we can consider this case as an ER positive.
Yeah. Do you have fulvestrant available?
We have.
You could do fulvestrant because it might one wonders if she has an ESR mutation at this point in her bones that might make her resistant to aromatase inhibitors. So maybe fulvestrant might be a good option for her. This is assuming it's hormone positive. I think I'm still going to advocate for it.
Right. So, other panel member for your expert opinion, Qamruzzaman Chowdhury sir.
They have shown that there is a mutational change in, especially like there is a decrease in PR and Ki67 in gain after having a lot of neoadjuvant therapies. So from bone, we can check whether the patients has changed into hormone positive or other mutation like PI3 kinase or other mutation are there or not. So in that cases, we can have other option because patient doesn't have use. I think the PERP inhibitors or irregular patient has not taken. If it is a hormone sensitive tumor, so we can use the palbociclib or fulvestrant in that case. So you need to do the bone biopsy and to check especially the hormonal ERP or other mutational status, especially.
In these particular cases, if the disease is triple negative, but the disease is progressing, so I think we should do the biopsy from the bone mass. This is the ideal protocol from my side. If it is not possible, if we think as the bone mass cases are more positive for ERPR positivity, so in these cases we can also use the CDK4/6 inhibitor, that is palbociclib plus fulvestrant and other exemestans. If it is triple negative breast cancer, in that cases we should do some tests, especially for BRCA. If it is mutant, then we can use the PARP inhibitor. And if in this case we can also do the PDL1. If it is positive, then we can also do atezolizumab. Or if it is BRCA not mutant, not PDL1 positivity, so we can proceed on another drugs, that is eribulin, that is halaben. This is my option.
That would be our approach as well. So I agree.
Okay, Mofazzel sir.
I have one or two comments first. This patient has received 12 cycles of anthracycline. Whatever anthracycline you use, I will not continue to use up to 12 cycles, because if you use doxorubicin or epirubicin, that is very likely to cause cardiotoxicity. So probably after 6 cycles, once the cardiotoxic dose has been achieved, or just before that, I will switch over to a platinum along with taxane. This is my choice and my comment on that point, right? And the continuation of aromatase inhibitor like letrozole and exemestane, I do not agree on that point, because it was found to be triple negative when it was diagnosed. But the recent development of the spinal mets and others, we do not know the status, because there is some changes in the receptor status, as Professor Don says. So we should go for a fresh biopsy. But if it still continues to be triple negative, we are left with few options, like as Dr. Salim Reza said, we can go for the PDL1 testing, and then, but if the person does not submit herself to any kind of biopsy, so we are probably left with very few options only, such as vinorelbine, eribulin, and paclicarbo or something, or platinum compound, or capecitabine, like this. These are just palliative chemotherapy. But new biopsy is imperative, and if possible, that should be carried out. Otherwise, I think the management that has been already elaborated by the previous speakers, I fully agree with that.
We are running short of time. From the audience, anybody have any question to our expert panel, you can ask.
Oh no, I was just wondering, there was a question about how bone biopsies are not ideal if you want to test it for metastatic disease and receptors, and quite frankly, it's not one that our pathologists like to use because of the fixation issues. But I was just wondering to hear from one of your pathologists regarding utility of bone biopsies in not only hormone receptor testing, but also genomic testing.
Yes, pathology point of view, yes, bone biopsy can be done. It should be decalcified, and then, and also the fresh tissue we can use for genomic analysis sequencing, which may give a clue about the primary, which lesion has metastasized, whether the primary first one or the second one. We can have an idea from the bone biopsy. And also regarding hormone hormonal assay, it may change. In the metastatic site, we may find a different type of hormonal response. So it cannot clearly designate that which tumor is this, which have metastasized. And also, I assume that this case could be might be a BRCA mutant case. So even for the first case and also for this case, I think patients should be surveyed for endometrial carcinoma also should also be considered, that should have clear supervision for excluding other cancer, because there are already there are two cancers, and both the cancers, I think those are two primaries, we assume. Those are two primaries, and it is possibly a mutant case, BRCA mutant case. So this patient should be surveyed for endometrial carcinoma and other possible carcinomas also. That is also an important point here. And bone biopsy, I don't think it will give additional any clue further, or it is difficult, and also it will be difficult to genetic. I think genomic sequencing is the most important question here, and should be done if possible. If it was possible in our country, that was the best option in this case, I think. And also, besides these things, I didn't know that Professor Don is coming from Rhode Island, because I was there. I was there. I had a fellowship at Brown University in 2013, and you must be knowing Professor Ruhul Quddus, the pathologist.
No. Oh, yes, Ruhul Quddus. Yes.
Yeah, you know, I think.
Yes, I know Ruhul.
Women and Infants Hospital.
Yes.
Yeah. So
I
it's
used
very
to be
nice.
at Women and Infants Hospital way back. So
Yeah.
I remember it very well.
Yeah, I was there. So I liked Providence so much so that I wish to go once again in my life.
Oh, good. Well, after COVID, more than welcome to come back, of course.
Yeah.
Thank you.
Thank you very much. Yeah.
I am there. I didn't make a question. I made a comment that for genomic testing,
Sure.
bone biopsy is totally discouraged, because bone tissue is not ideal for any genomic testing, because when it is decalcified, it loses its nature. So genomic testing is not recommended from a bone tissue. That was my comment actually. So I have no comment about the ERPR, and John also agreed with me that we should not proceed for any bone biopsy, because there is a limitation as a tissue when we decalcify and do the genomic testing. So for the molecular profiling, they always tell that to take tissue from any other site, but not from the bones. I wanted to hear from him also on that. Thanks.
No, I mean, I agree. Unfortunately, in a case where your only metastatic site is the bone, we actually debate this quite a lot at our institution as to whether it makes sense to do the bone biopsy, especially for the information you want, which is exactly the point being made. We would, our pathologists are very, very careful when they send out tissue from bone for genomics, for the very reasons indicated, that you might lose some of the sensitivity due to the process of decalcification. I think if I had to, in a limited resource setting, send it for genomic testing, I would go with my clinical suspicion that her bone mets are from the hormone-positive breast cancer. And if I had to, I'd send for genomic testing on the primary breast in the hormone-positive disease and see if there's a PIK3A, for example, mutation that one could do. Now, with genomic testing, the other benefit is you would also get tumor BRCA or HPV testing done. So you could actually get a lot of information from the breast tumor itself.
Absolutely agree, sir. So we're almost at the end of our tumor board. It has been a very wonderful and lovely discussion. Thank you, Professor Don S, Dizon, sir, for spending your valuable time and coming and discussing. We'd love to have you in our future discussion as well. We are planning to continue this tumor board for a long time. Hope we'll get you in our future boards as well. Thank you, sir. Thank you for being with us. Thank you, GCI, for your excellent collaboration and supporting BSBCS for this board. At the end, I'd like to request Professor Qamruzzaman Chowdhury sir to say a few words and to conclude this session.
First of all, thanks to GCI especially, and thanks to Professor Don Dizon especially. He's a very busy man, and he has given 1 hour's time for, because it's a working day also in his places. And yeah, we also shared our 2 cases, and we got the ideas about how to plan in our settings actually. So we're very much pleased for attending these programs, and thanks to all the participants, especially our other panelists like Professor Salma Sultana, Professor Khadijun Nahar, and Professor Dr. Salim Reza, and others. And thanks to JSA, and thanks to all the participants. And hope we'll again meet in the next month, especially with the other cases. Thanks. Thank you all.